Good morning and welcome. I'm excited to be here. My name is Dr. Lisa Park, and we're here for a CyberSite webinar on Phaco Fundamentals. This is the second in a series. I'm very delighted to be asked back after doing a session on basics and introduction to phacoemulsification. Let's see if I can see my slides here. Fantastic. And so I just want to say hello to everybody. Just to give you some information, I am a cataract surgeon. I have been on the faculty at the New York University School of Medicine for over 10 years, practicing in New York, in Midtown Manhattan. My passion is surgical teaching, and I've been honored to be able to teach a number of residents through the years, and also too to participate in surgical teaching around the world. I know there are a number of you who've logged on from Ethiopia, so I just wanted to say a quick hello to my colleagues that I've been working with in Addis Ababa. And I also recently just returned from Pondicherry, India, and was very excited to participate in the Phaco Excel course that was put on by the Aravind Eye Hospitals. So I would say hello to all my Indian colleagues who are also joining us today. I encourage you to look at a couple of surgical educational materials that I've been involved with. The BCSC series is revised every 3 years, and the Lens and Cataract book has been updated as of this year. And so the cataract surgery section has been markedly revised. I encourage you to take a look at it if you haven't read it in some time. And also I encourage you to look at the ASCRS Center for Learning, and particularly the Phaco Fundamentals classroom. A number of us who are educators in the US are involved with vetting materials and finding resources for the new Phaco surgeon. And so I hope that these are helpful to you. I just wanted to start by showing video of this is a typical case in a patient that doesn't have, well, has, I guess, a fairly significant lens. And this is the type of surgery that I'm doing traditionally. And that is when there's not a lot of view, staining with trypan blue, doing a clear corneal incision, performing a continuous curvilinear capsulorhexis. And then this would be a traditional stop and chop case. So making a groove and then using a horizontal and vertical chopper to break this lens into a number of pieces, and then bringing them up individually, these pie-shaped wedges. So you see that's a horizontal chop. And using the fluidics of the Phaco machine in order to maximize efficiency. And we're going to talk about some techniques and strategies for being efficient and using as little energy and fluidics as possible. And here, this is injection of a one-piece Acrosoft lens, inserting into the capsular bag, and removing viscoelastic with bimanual irrigation and aspiration. So I just wanted to show just a very straightforward case. So we have a starting point to talk about and to work from. And I understand that, having operated around the world, that we're all under various conditions. So technology is different in different places. The access to instruments and materials is different all over the world. And the main point is, as I'm showing you the videos that I have, the main point I want to stress is just because you drive a sports car doesn't mean you're a good driver. So in other words, it doesn't depend, you can't depend just on your technology and machinery to achieve what you need to achieve. Many surgeons tell me, will say, of course, if I had the machine that you had, I'd be able to do what you do. And I'll say that it's really important, an understanding of the principles is more important than actually just having access to this technology. So I'll just talk about, just to give an overview of the machinery and the equipment that I'm using. So I operate with the Zeiss Lumira microscope. I also happen to like the Leica scopes very much. And the machine that you'll see here in many of these videos is the Alcon Centurion phaco machine. I have gone to this from having used the Alcon Infinity. There are, of course, a number of other very, very good phaco machines that are available to you. And I've also operated with tabletop machines in the developing world. So I understand that there is a wide range. I operate through a temporal clear corneal incision, and the blade I use is either a 2.4 or a 2.2 millimeter incision, and that has come down from where I initially trained 10 years ago, being in a 2.75 or 2.8 millimeter incision. The phaco needle that I like to use is a 45-degree balance tip, and in my previous talk, we talked a little bit about the choices that you have regarding what your phaco tip looks like. You'll modify your technique according to what machinery and instruments you're using. I perform a continuous capsulorhexis using a 27-gauge cystotome. I tend not to use a capsulorhexis forceps simply for the sake that, number one, it's harder to do in a smaller incision, although the instruments have gotten smaller and smaller, so now it's not so difficult. And number two, I happen to like it because very often when you go, especially to places where you don't have access to your own instruments, that those forceps can become easily misaligned. And so if you have your own system and bend your own needle, you never have to worry about that. The chopper that I use is a Cybele horizontal and vertical chopper, and I like these because they have generally rounded edges on the distal aspect to protect the bag, but of course there are a number of other choppers that are available to you. The consumables I use, I like the intraocular lenses from Alcon. My go-to lens is the Acrosoft one-piece lens, and I also use this 3-piece foldable lens. And then my viscoelastics that I tend to like to use include 2 categories, and we're going to talk about this in detail, and that is I use Helon as my cohesive, and I use Visco as my dispersive viscoelastic. So today I'm going to be talking about a little bit of a variation on what I had announced, and that is I'll talk about 4 topics today. The first is going to be phaco-dynamics. We'll talk about viscoelastics and your access to consumables and the importance of making certain choices. We're going to talk about biometry and choice of intraocular implants. And then lastly, I'll talk about the small pupil use of rings and also use of rings for the pupil and rings for the capsule. When we talk about phaco-dynamics, there are 3 main parameters that we discuss. So the first is power, and the goal is to use enough power to be efficient but not more than needed. We're going to talk about irrigation, maintaining a stable anterior chamber, and vacuum, and that is achieving purchase and grabbing onto your pieces and avoiding post-occlusion slurge. So the first is power, and the goal is use enough power to break up your lens, but don't use more power than necessary. And why is that? We're trying to prevent clouding of the cornea, and we're trying to prevent the possibility of grabbing onto the capsular bag. Your choices include multiple ways of modifying your phacoemulsification in order to minimize the amount of energy that you use. One category is direction of the needle, and the second category is timing, and we'll talk about both. When we talk about traditional longitudinal continuous phaco, what we're talking about is this, a phaco tip that's being pushed forward and back. So just we see in this video. So this is the traditional forward and back motion. We believe that this breaks up the lens using a physical jackhammer effect, as well as the formation of cavitation bubbles, which are then also using their energy in order to break up lens material. And let's see if we can put this down here. This has been modified with various other modalities. So transversal ultrasound combines a longitudinal forward and backward motion with a transversal elliptical motion, and these motions happen simultaneously. to show us this. And so this combination of a forward with a transverse motion then provides additional physical energy to break up this lens without converting into additional dissipated energy that affects the endothelium. And then we also have torsional ultrasound. And this is a movement of the phaco tip in a semicircular fashion. And this allows, again, further breakup of the lens without causing energy that can affect the endothelium. And this is something that's specific to the Alcon machines and is very effective and enables us to really break up this lens easily. You can see that there is advantage to using a beveled tip, a 45-degree tip, and an angle tip in order to maximize the physical energy that is used. So that's direction, and that it will depend upon the machine that you're using. The second aspect is timing, and that will depend upon the mode that you choose to program into your phaco machine. So there are two main categories, and that is pulse and burst. So if you think about continuous phaco, when you're pressing down your foot pedal, the greater amount that you press, the more energy you will achieve. So that's linear phaco, and that will be continuous 100% of the time. If we talk about pulse, this is our ability to depress the pedal and then allow there to be an on and an off time that's programmed automatically into the machine. The more you press, the greater your total phaco energy will be, but there'll be some time where the phaco is off, and so you can minimize the amount of energy delivered. And you can see here that you can set the limits of your phaco power and then the percentage of time that the phaco is on, or the pulses per second. We call this the duty cycle. Phaco burst is another modality in which the phaco power is actually set at a certain level, but the greater amount of pressure you put on the pedal and the further down you press, the closer together those bursts of phaco will be. And if you were to press 100% of the way down, then you'll just get continuous phaco. And so this shows you how many milliseconds between each of the bursts, the minimum and the maximum, and allows you to, again, adjust for the amount of energy, the amount of time that the phaco is on. What this could be very helpful for is actually to grab onto a large chunk to burst in and then allow you to grab it is very helpful with this phaco burst. So this is just a diagram to show you the differences in power modulation. So phaco continuous versus pulse versus burst. You can set these on various machines. On the Centurion, you can see here that when you press this button, it now allows you to change from continuous to pulse to burst. And you can see here that it's separated out the longitudinal versus the torsional. And so in most of my cases, I've eliminated longitudinal and I've gone simply to the semicircular motion of torsional. And I find this to be very effective in these cases. And this can then limit the amount of dissipated energy that is delivered to the endothelium. And let's see here. And so you can see here, this is a 94-year-old gentleman with a relatively dense lens. Here's the longitudinal setting here, which is 0, and torsional, which is linear, with a max of approximately 80. You can notice this is the dissipated energy over here. This is my aspiration and vacuum settings, and this is the level of intraocular pressure. And so this would be a traditional stop and chop. I've grooved, I've cracked, and then I'm going to go ahead and using higher vacuum chop this lens. And so we can see here utilizing again this chopper to engage, and the vacuum is approximately 475 would be the maximum in order to then bring these pieces up and out of the capsular bag once they've been once the nucleus has been disassembled. And so now this would be a horizontal chop. I brought the lens up using high vacuum, and then you can see here the amount of torsional energy that's being used. And so this is linear, and I'm using chop to break up this lens into smaller and smaller pieces. And then utilizing simply phaco in the vacuum. This is just bringing up this entire lens. And so you can see here, our amount of dissipated energy is quite low. So I think we're going to end up under 10 CDE. This is bimanual irrigation aspiration. I like the Katina hand pieces. The key here is that your aspiration should be smaller than the irrigation in order to achieve your stable anterior chamber. And you can see that I've maintained a pretty high IOP. And so this enables me to do this without collapsing the anterior chamber. This is actually auto insertion of the Acrosoft lens and centration. And again, irrigation aspiration. The second principle is, in addition to minimizing the amount of energy, we want to minimize fluidics. Don't use more irrigation than necessary. The more we are irrigating the cornea, the more you're losing those endothelial cells. I will address a question. Somebody had put in a question, what is your cutoff point for your specular count to decide on whether to do phaco along with a DSEC? The answer is, I like to see a specular microscopy count greater than 2,000. Under 2,000, then it comes down to what do the cells look like, how much polymegathism is there, polymorphism is there, how much guttae are there. But even with all that, let's say I see a lot of guttae, let's say I see 1,000 cells, even then it doesn't matter. You're measuring what the function of the cells is, and I will counsel a patient if there is, I'll take phacometry, if their phacometry is normal. We're going to proceed in all cases with phaco first, and then see how the cornea does. If the edema is unresolving, then we'll proceed with a second procedure, such as a DSEC. But we don't do that primarily, if possible, unless it's completely necessary. But in general, we do the phaco first, and we counsel according to the cell count and according to function. Okay. So now the technology exists where hanging the bottle has been replaced with bags that are actually in the machine that are actively compressed. And so there are plates that will adjust and deliver the fluid so that you can just adjust the IOP. This is active fluidics. There's a sensor which senses how much fluid is coming in. And so this is the state of the art now. Of course, this is not widespread. So adjusting the intraocular pressure by bottle height is very important. And so when one is operating, it's very important to ascertain if you're not getting good anterior chamber stability. You have to ask yourself one of two things. Number one, is your wound leaking? And number two, is your bottle high enough or is it empty? And so these are important things to consider. What I like to do is bring the bottle down as low as is feasible in order to maintain an anterior chamber to prevent this just turbulence inside the eye. And that's my goal here also. If you can get a lower IOP and still maintain the anterior chamber, that is more ideal to save the endothelium. So let's talk about times when you would adjust your bottle height. One would be right here, and that is in the case of posterior capsular rupture. So here, this case seems to be going fine. There's some epinuclear material. However, as we notice that there's an opening in the posterior capsule, and we're going to immediately drop our IOP. Actually, we don't do it right here. So this is a little bit high. And you can see that I have not taken out the phaco handpiece, but immediately put in a dispersive viscoelastic with the intention then of trying to get out the pieces while maintaining that aspect of the capsule. So here, let's see. So you'll see, so I've dropped it from 80 to 55. And so in doing so, I'm hoping not to hydrate the vitreous. I'm hoping to keep these pieces a little bit more stable. And you can see here, not entirely successful. A little piece falls behind. However, we're still able to place a lens into the posterior chamber. So again, we're adjusting the bottle height according to the situation. And here you can see this is the equivalent bottle height. This is the IOP that's in this particular case. And then principle number 3 is don't use more vacuum than necessary. So it depends upon what aspect of the case that you're performing. So when we talk about vacuum versus aspiration, aspiration is how quickly the pieces are going to be attracted to the tip when it's not occluded. And vacuum is how tightly the nucleus is going to be held to the tip when it is occluded. And so the key here is you have to achieve total occlusion of the tip in order to get your maximum vacuum. And so oftentimes I'll see people try to raise their vacuum when they haven't occluded the tip, and they're thinking, how come I'm not grabbing these pieces? And the answer is maybe you're not completely occluding. So your physical movement of your handpiece to get the full occlusion is very important. An adjustment of choice of phaco tip. So sometimes I'll have residents where we've gone to a 45-degree tip, they're not getting full occlusion, and so they're trying to increase their vacuum, and my answer to them is let's change back to a 30-degree tip, make sure you have full occlusion before we go ahead and make that change. And so let's see here. And this is a case of phaco flip. So what I'm doing is I'm doing hydrodissection and then actually trying to get this lens up a little bit into the anterior chamber. And in doing so, then I will use high vacuum immediately to grab this part of the lens and tilt it up and out of the bag. You can see that it's just completely flipped over. And so I know I have full access. So I will not need to chop this lens. It's not that dense a lens. And therefore, I'm just going to use high vacuum to grab it and to simply phacoemulsify it. And I'm in the anterior chamber in this particular case. There is another question that was asked, where is the ideal space to perform chopping of the lens? Is it anterior or posterior chamber? The ideal place is the posterior chamber. It's more ideal to save your phaco energy and get the lens broken up in the posterior chamber if possible. But we use our chopping techniques in the anterior chamber, as you can see in this particular case. Okay. And then again, this is the importance of high vacuum to perform a vertical chop. So you can see here, here's vacuum. We have to completely occlude, completely bury this tip in order to be able to grab that lens and to perform that vertical chop maneuver. And you can see here that the vacuum is linear. So in other words, I've adjusted it so that when I press the pedal, more I press, the more vacuum that I get. In this particular case, you can see I've set my baseline setting at 100 and my maximum setting at 475. And in doing so, what I noticed here is that my pieces are a little bit too jumpy. I don't like the way that this is acting here. You can see that that the pieces are not coming so easily. So you have to ask yourself, is it there's lack of full occlusion? Are the pieces not completely disassembled? Why am I not able to achieve what I need to achieve here? And sometimes what you'll see is that maybe your parameters are too high. So in other words, if I don't have a smooth flow of the nuclear pieces, then I'm wondering if perhaps these are not the correct settings to use in this particular case. You can see that I'm eating directly through these pieces. They're not coming very easily. And so what I've done in this particular case is I actually lowered my baseline vacuum from 100. I went down to 0. I said, you know, maybe we need to have a little bit more time for those pieces to be grabbed onto before they're phacoemulsified. And so you can see here, I have all torsional. Actually, this is a dense lens, so I'm using some longitudinal. And I've lowered the vacuum so that it starts at 0. And now you can see that the pieces are really, it just gives me an extra millisecond for me to be able to grab that piece adequately and bring that up. So mild adjustments in the settings can be very helpful in these particular cases. And so you can see here my aspiration maximum is at 32, and this is how quickly the pieces will come. And then the vacuum allows me to phacoemulsify and really hold on and grab those pieces adequately. So my take-home points are: your goal is to use only the power needed in order to phacoemulsify your lens, and not too much power. Second is use your irrigation to maintain anterior chamber stability, but lower in cases where you need to make adjustments. So be aware of where your bottle height is. And number 3, your vacuum and aspiration. Your goal is to achieve effective purchase. So use your linear modalities to your advantage. So that's phaco-dynamics. We're going to move now to, so 2 quick things, and that is use of viscoelastics. Okay. So what are viscoelastics? These have various viscous and elastic properties. They can be thick or thin. They're elastic. They change shape under different shear forces, and they coat various tissues. Why are these important? We obviously are protecting the endothelium. We can create space. We can manipulate tissues. A survey of cataract surgeons in the US indicated that 68% of surgeons use only one OVD for routine cases, but the vast majority of us adjust the OVD in complex cases. And so I'm just going to talk about those here. So I want to ask this question because I know that these are consumables that are hard to obtain. So my question to you is, for those who are operating regularly, do you have more than one OVD available during surgery? The answer is yes or no. And so if everyone can submit their answers, let's see. So I don't know. So do I submit this here? And let's take a look and see what our results are. Okay, so yes, so 2/3 of you do have more than one OVD available. So we're going to talk about the differences and when we use them. A third have one. If you have one, you got to use it. So, okay. What are these made of? They're generally made of sodium hyaluronate and chondroitin sulfate. But the important thing to know is if you were to look at the composition, you can't determine what the how the OVD is going to act based on the fact that sodium hyaluronate, which is the most common. It's going to be the length of the molecular chain. So don't be fooled. You have to know which category they fall in based on the length of the molecular chains. So the 2 main categories include cohesives and dispersives. And this is a video that's going to show how these act. A cohesive is on the left, which you can see is long molecular weight chains that bind together. And the dispersives are short molecular chains that are more viscous, and they tend to coat tissues better. So here are the long molecular weight chains and the short molecular weight chains. And this is a video that shows why is this important. It also is important when we remove them from the eye. So this is a cohesive viscoelastic. You can see once you grab part of it and you aspirate, it's going to come up as a single long chain versus your dispersive. So you can see here, when we take these out, these are going to come out individually. And the importance of this is dispersives that are used need to be removed in their entirety, because if you have viscoelastic that remains, this is the source of your intraocular pressure spike post-op day 1. And so these need to be removed carefully. These are categories of cohesives, again, like Provisc, Helon. These are used to create or maintain space. And so this is just a video showing, I like to use cohesives in the case, this is a floppy iris syndrome case, where I've used a ring to push the iris back. Cohesive is nice to be able to put your lens in the bag very easily, and then maintain space in the anterior chamber in order to then go ahead and remove this ring easily. And you can see here, as removing it, it comes out almost entirely with just irrigation. So again, this is a long molecular weight chain, so it almost bursts out of the wound. And so I like to use this at the end of the case simply because I know that I can perform very quick irrigation aspiration to remove the viscoelastic. The second category is dispersives, which are smooth. They like to coat. So this would be your viscoat, endocoat, ocucoat. And these are used majority of the time to protect the endothelium from the energy of phacoemulsification and the turbulence of fluidics. And this is very important to tamponade vitreous in the event of a posterior capsular rupture. And so this is a dispersive OVD. So this is a case in which most of the nucleus is out. I'm actually performing a little bit of endonuclear removal carefully. What you can see here is I'm trying to remove this endonuclear shell, but I'm starting to wonder if there's an opening there in the posterior capsule. And so as I'm doing this, I'm looking very carefully at that very bright red reflex and thinking to myself that the posterior capsule is open. And so the thing to do is to inject a dispersive viscoelastic, and now I'm checking to see what's going on there. And you can see in this particular case that it looks like there's a central opening there, but I've walled it off in order to carefully remove the material that's on top of it. And I'm using those small molecular weight chains in order to fill this space. And what's nice about this is it actually turns out there was no rupture in the back, but I've actually filled with those small molecular chains in order to protect that area in order to perform the rest of the removal safely. There are dual viscoelastic systems that are sold which combine both. And I like to use this Arsenoff shell technique to really protect the endothelium. And it is a combination technique. So you can see here that we're going to go ahead and inject, that's the dispersive, and then a cohesive underneath to really press up and protect the endothelium. And I like the way that the cohesive presses down on the anterior capsule in order to perform the capsulorhexis. And you can see here during phacoemulsification, a lot of the viscoelastic is actually aspirated. But when you have a nice coating of the dispersive, that really protects your endothelium. I use a cohesive to then go ahead and inject the implant. And you can see here that many people will go ahead and irrigate and aspirate underneath the implant in order to make sure that everything is removed from the eye. This is the technique that was popularized by Steve Arsenoff, and this is what I use very often in my cases, especially in cases where you're worried about the endothelium. So again, in cases with low specular microscopy counts, low endothelial cell counts, that's your dispersive. And then you can see underneath, I'm just gonna go ahead and place the cohesive. And now I'm coating the endothelium. This is really pressed down my anterior capsule in order to perform the capsulorhexis. There are some variations that try to do both, so like Helon 5 or Discovisc, and these are long, long molecular chains that are very fragile, so they will change their behavior based on shear stress. And you can see here, this is just you can see what it looks like outside the eye. So when do we modify? I modify based on challenging cases. So shallow anterior chamber, floppy iris syndrome, pediatric cataracts. So I'll just show a few examples. So this is a case from my friend Uday Devgan at UCLA. And what he likes to do is use this very heavy viscoelastic in a case of floppy iris syndrome where the pupil is not so large. And you can see he's using this very dense cohesive in order to dilate this pupil and maintain it during the case. I like to use a very dense cohesive. You can see this is, again, a floppy iris syndrome case, trying to manipulate that iris, put that back inside the eye, and then really weigh it down in order to go ahead and perform this surgery in this particular case. This is a case of a pediatric cataract. This is a video from my colleague and friend Mark Lustig. So in a pediatric case, the capsule is very rubbery and acts in a very different manner. So you can see here that it can run out at any time. And so the use of a very dense cohesive viscoelastic can be very helpful in order to tamponade the capsule to prevent it from running out during the capsulorhexis. So in summary, your cohesive viscoelastics maintain space, and highly cohesive OVDs can be used in complex cases such as pediatric cataracts and floppy iris syndrome. Your dispersives coat and protect the endothelium and can be used in order to prevent corneal edema, and they can compartmentalize the eye in posterior capsular rupture. So I highly encourage you to vary your use of OVDs in various types of cases. Okay. So we're going to move on to biometry. I know that the availability of intraocular lenses varies around the world, my challenge to you is in the United States, we have now become refractive cataract surgeons where it's not enough to just take out a cataract. We need to really be spot on with the implant that we put in. And patients are expecting to not only see better, but to see perfectly without glasses. And for that, biometry is critical, and the availability of various lenses is critical. So I'd like to ask, and I know that we don't always implant a lens, and so depending upon your access. So what I'd like to ask is, in what percentage of cases are you implanting an IOL? Is it no cases, no access to IOLs, less than 50%, greater than 50%, nearly 100%? And I understand that also in many parts of the world that it depends upon the patient's ability to pay. So the choice of implant will depend a lot on not just access, but cost. So let's see, what percentage of cases do you implant an IOL? Okay, so the vast majority are placing an IOL in the vast majority of cases, so that's good to know. Okay. And you choose your IOL based on biometry, yes or no? So in other words, are you measuring the eye before choosing the implant that you're putting in? I know that in many places that we're using an average length eye in order to choose the most likely implant that will be helpful. Okay, so the vast majority are put, so I'm very happy to hear that because I've been to places where that's not the case. Okay, excellent. Okay, so I'm just going to talk about what are the advances in biometry and advances toward getting that perfect 20/20. Measuring the eye. We know that you can see here that, that there is a very wide variety of obviously refractive error. Okay. I operate in Addis Ababa, Ras Desta Hospital. It's a city hospital in the capital city. And you can see here, they've, over the last number of years, documented exactly what IOL powers they're putting in. The vast majority of them are right here, 20, 21, 21.5. But you can see they vary, obviously, very widely. And so I just want to make the point that it's very important to consider your implant carefully. And then my other question is, what is your target refraction? Are you aiming for plano? Do you aim for mild myopia? Or are you using standard IOLs for every case? And I would say this is in the vast majority of cases, plano, a little bit minus. And this is something that I commonly see is that because of not difficulty accessing glasses after surgery, that many places are aiming for myopia, actually. Okay, so yes, and I think that is a very common thing, aiming for a little bit of myopia versus plano, and we'll talk about some of those choices. Great. So obviously, the two main measurements that we want are the axial length and the corneal curvature. And so ultrasound biometry is critical, taking good measurements, looking for the appropriate spikes. This is immersion biometry, which is considered to be a little bit more accurate simply because it eliminates observer error. So in other words, if you're pressing harder with your ultrasound probe, you're going to get inaccurate measurements. And then this is manual keratometry. So this is basically reflecting light off of the surface of the cornea and then ascertaining through calculations of the reflection of those images what the corneal curvature, average corneal curvature is. And in manual keratometry, this is about 3 millimeters away from the center of the eye. So what has evolved? We've evolved into now optical biometry, and that is the use of light in order to take those measurements of the length of the eye. It's infrared light that calculates the axial length, and it uses partial coherence interferometry. You can see here that this is the IOL master, and this is the Alcon lens star, and the number of spots will determine the accuracy of your measurements. What are the pros? The pros are this is non-contact. So in other words, this really minimizes inter-observer variability, and it may be more accurate simply because it gives you a refractive axial length rather than an anatomical axial length. The cons are you can't use it 100% of the time. It will not penetrate through corneal scars, dense cataracts, PSC cataracts, so you have to have access to your ultrasound. It also requires patient cooperation and fixation to look into the target, and there's also, of course, the issue of cost. When we talk about topography and measuring the cornea, there are 3 basic techniques now: Placido disc reflection, scanning slit elevation, and the Schonpflug principle-based assessment. This is the traditional Placido disc. So this is basically reflecting circles onto the eye. You can see here immediately if there is some steepening or irregularity based on the concentric circles. And this would be a typical Zeiss Atlas corneal topographer that gives you some indication of the regularity or irregularity of the cornea. Scanning slit elevation uses a projector and a camera to project these slits onto the eye and then to interpret their reflection back to the camera here. And this allows us to analyze both anterior and posterior aspects. And this would be scans that you see, such as the BNL orb scan. And it gives us a lot of information, not only of the anterior, but posterior corneal curvature, which can impact, obviously, our refractive error. And the last is a very complex Schonpflug principle, which basically shows us that if you were to reflect an object, that you can adjust the image plane and calculate out this intersection, which gives us many, many points on the surface of the eye, and gives us images such as this. And this is the Oculus Pentacam. This is what I use, the Schonpflug principle, that gives us a lot of information about, again, the anterior and posterior curvature. And now we've moved to even intraoperative calculations on the table. This is the Aura intraoperative aberrometry. So we go ahead and do the surgery. We take the cataract out. We then remove the aberration from the lens, and we can then theoretically calculate really what the contribution of the corneal curvature is directly. And this requires patient cooperation intraoperatively, and then allows us to then actually even choose an implant and then again calculate out what the refractive error is going to be right on the table before the patient leaves the operating room. So these are the measurements and advances in measurements that have occurred. Number 2, more predictable calculations. This is the traditional SRK formula, which shows that very simply, the calculated IOL power should be the A constant minus the power of the cornea and the axial length of the eye. We now know that there are other contributions to calculations, which include the effective lens position. And you can see here that the lens position varies quite a bit. And so this is important to consider. And we now know that there are many, many calculations that are available to us. And I will say just, there are many, many talks that are given based on what we believe to be the best for not necessarily just the normal eyes, but for the eyes at the extremes, the short eyes and the long eyes. I will say that I personally like to use the Holiday 2 for the long eyes, and I use the Barrett for really quite a range. we know that refractive procedures are now causing us to have miscalculations of the corneal curvature, and so it's very important to take this into consideration. In my hands, the Barrett calculator has been very helpful in this particular case, and so this is what I spend the majority of my time now in preparation for surgery, is doing all of these IOL calculations and then making a comparison, choosing my best possible implant in order to try to achieve the refractive outcome that's desired. This is a very good website. Warren Hill's website gives us a lot of information and can be very good for those unusual cases. And also the Barrett calculator on the ASCRS website is also become very, very popular in the last year or two. And then third is premium implants. So solving presbyopia, we have the accommodating lenses on hinges and the multifocal IOLs. I personally am not the hugest fan of the accommodating IOLs. I don't feel that they are very, they don't work over time. The multifocals, we have to be very careful because of the problems with glare and halos. I tend to use this implant for refractive error, and that's the toric for astigmatism. I think this is a very good premium lens and has been very effective in the patient with over a diopter of astigmatism. And we now have just come out new implants such as the Symphony, which combine the toric implants with the multifocals, and they are touting an extended range of vision in order to get better presbyopic correction. The main point that I want to make is that one size does not fit all. So measure your eye and choose your IOL accordingly. One of the things that we don't have time to talk about is my choice in the absence of a premium IOL is to perform a lot of what I call monovision, and that is putting the implant into the dominant eye aimed at plano, and then going for a little mild myopia in the non-dominant eye. And mild myopia, I would say I would go to about a -1, or in a patient who has had the experience of monovision previously, I will go up to a 2 diopter difference in the non-dominant eye if a patient is able to tolerate that. What I feel that that does is it gives us a range of vision, so a patient's able to walk around without glasses, look out at distance, but then I tell them with a mild monovision, with a -1, they'll able to look at their watch, they might be able to pick up a newspaper, they'll be able to go to a grocery store, pick up things off the shelves without the need for reading glasses. And so this, I think, is in the right patient is a good option. I would say that 70% of patients will tolerate this. About 30%, 25%, 30% will not tolerate that difference, even a very mild difference of a -1. So it's important to really assess preoperatively your patients, and I listen very carefully to what their optical needs are. So somebody like myself as a microsurgeon, I do not tolerate that difference at all. And so, depending on a patient's vocation, what they're doing on a daily basis, I'll make that decision and discuss with them whether that is a possibility. So that's optical biometry and the importance of choosing your IOLs. And the last thing we'll talk about here is, let's talk about small pupils and use of rings. This is the ring from the movie and book Lord of the Rings. So I'm going to ask, what is your preferred method of handling a small pupil? Do you do a sphincterotomy with scissors? Do you stretch with hooks? Do you put in iris hooks, or do you have access to pupil expander rings, such as a Malyugin ring? All of these are equally valid. It, of course, depends upon what you have access to and what is available to you. And of course, the clinical situation at hand. So let's see. Sphincterotomy versus stretching. Okay, so a large number are using iris hooks. Availability of pupil expander rings, of course, can be limited. A sphincterotomy can be very, very, very helpful, especially in those scarred down cases of pseudoexfoliation. There's even putting in rings or hooks is not necessarily going to be helpful. Okay. So I'm going to talk a little bit just about the Malyugin ring. This is my go-to pupil expander. There are many new ones that have come out there, but I've used this the most. It comes in two sizes, 6.25 millimeter and a 7.0. In a case I know of floppy iris syndrome, I'll go ahead and put the larger ring in. It's a little bit more difficult to maneuver. The 6.25 is the most popular, and you need to be in a greater than 2.2 millimeter incision in order to insert this ring. In order to place the ring, the Malyugin manipulator, which has this little knob on the end, is very, very helpful. You can do this with a Kugeln hook or a Sinski hook, but I found the manipulator is a very nice tool to have. And so you can see here, this is a relatively small pupil, and we're going to go ahead and you can see that this is through a 2.4 millimeter wound, and so this inserter fits in very nicely. We're going to engage the distal part of the iris. And then we got very lucky in that the two other scrolls were also engaged. And then let's see here the next video. And then this is the use of the manipulator in order to engage and center this ring. And this is a 6.25, I believe, in this particular case. And so let's just show a case of intraoperative floppy iris syndrome. And these are some of the modifications that I do in these particular cases. So the use of trypan blue, I just like to make sure that we're seeing what we need to see, especially if you're going to anticipate that this pupil is going to come down. I use the Arshenov shell, as I mentioned previously. And in particular, in a floppy iris syndrome case, I like to have that cohesive dispersive, giving me just a little bit of extra measure here of assistance. So in this particular case, I know this patient is on a prostate drug. However, I've proceeded because the pupil didn't seem too bad. You can see here I've grooved and cracked. And now, as I'm starting to engage the lens, I am looking carefully actually at the pupil and the activity of the pupillary margin. I don't like the way that this is bouncing down in this particular case. I'm not paying attention so much to the fact that I can't engage the lens, but I'm looking up. That pupil is really starting to come down. I have epinephrine in my bottle at all times. I've used phenylephrine, cyclogel, and medriosil in order to dilate that pupil preoperatively, but that pupil is going to come down. And so you can see here I'm now putting a cohesive viscoelastic in, and look at that pupil, that iris. We know that it's going to prolapse out of the wound, and so I'm going to go ahead and put a Malyugin ring in. The important thing here is that you don't want to engage your capsulorhexis, and so I've put it on top of the iris first and then manipulated that into place. And you can see here now things have markedly changed. I don't have to worry about the fluidics and maybe that piece of the iris engaging into my phaco tip. And so the case can proceed normally. The Malyugin ring has now come out in a thinner version, so you can see that those, it's a polypropylene haptic-like material, and they've actually come out with, recently, with a more flexible, malleable, thinner version of this. But I feel that the traditional one has really done quite well for me. And so you can see here that I keep the ring in order to perform the cortical removal. And in this case, I've decided to keep it in as I'm putting the lens in. You have to make the choice whether to keep the ring in before you put the lens in. And sometimes I'll remove it beforehand if I think there's going to be difficulty, because if that IOL expands before you are fully in place, you can engage that ring, and that can be a little bit difficult to then get that out. And in this particular case, because that iris was prolapsing through the main wound, I've put a stitch through the clear corneal incision, simply because I don't want that to be a nidus of infection and possible endophthalmitis. Okay. So my question here to all of you is, what do you do in a case with zonular dehiscence now? We're moving away from problems with the iris and moving to capsular problems. Would you leave the patient aphakic if you get a zonular dehiscence? Place an antechamber IOL if you have that available suture a lens to the iris, suture to the sclera, use the capsular tension ring, and then put an IOL in the sulcus or in the capsule bag? Or do we hope that this just doesn't occur and avoid these cases altogether? So we've got a lot of choices here. And I would say this is just in, you know, obviously we adjust according to the type of case. But I'm going to say, in the case I'm going to show you, this is what I'm going to do. Okay, so vast majority of people are using capsular tension rings. So hopefully I have something interesting to show you then. Let's see. Okay, these are the capsular tension rings. They're put out by various companies. This is stabilized by AMO. It comes in 2 sizes, at the 1210 and 1311. The larger number is the ring diameter in the uncompressed state, and the smaller is when it's in the compressed state after you insert it. This is the mortar ring put out by FCI Ophthalmics, and you can see again it comes in multiple sizes, and so you adjust according to the axial length of the eye and how large you think the capsule is going to be. It's a little confusing here because the smallest one is a 14 and the largest one is a 14A. The average one is this one, the 14C. And then you can put it in manually, or you can go ahead and inject it with an injector if you have that available to you. So I'm going to just show a case of zongular dehiscence with a CTR insertion. So this case has gone well. I'm at the very, very end. I'm removing the cortex. And as I'm removing the cortex with my bimanual irrigation aspiration, it's the very last piece here. And I'm looking, okay, we seem to be home free. Everything seems to have gone well. But as I'm grabbing this last piece, something is a little strange. I said, oh, it looks like there's actually a dehiscence right there. You can see it right there. And so I'm going to make the decision to put in a capsular tension ring. These work ideally in cases where there are 3 clock hours or less of dehiscence. Once you get to 6 clock hours, this becomes a little bit more unlikely to be successful. So again, it's 3 clock hours or less is the most ideal to go ahead and put this in. And then you can see here, once we put that in, things have been stabilized, and I'm going to go ahead and put a 1-piece into the bag. Some would argue that it might be better to put a 3-piece, and I would say that's equally valid to get that sort of help from the haptics that are going to push out there to give yourself a little bit of extra measure of support. So I'm going to be very careful in placing those haptics into the capsular bag. So that's rings. I'm sorry I rushed through a little bit, but I want to make sure we covered all these topics before the end of the hour. I think we have a number of questions, and so let's see if I can see some of these. Yep, somebody has asked, what is the approach for left-handed trainees? And the answer is, go ahead and use your left hand, your dominant hand. I actually had a trainee I've had multiple trainees who are left-handed, and all you need to do is, rather than putting your wound directly at 12 o'clock, you might want to put it just slightly to your left. I had the experience where I had a left-handed trainee and somebody tried to make them operate right-handed, and I would say, you don't need to do that. Use your dominant left hand as your phaco hand and just move your wound a little bit to the left side, and use your right hand as with your second instrument. So you know, do that accordingly. If you're with a teacher who's right-handed, what they will need to do if they need to take over is they're going to just move the scope, and they'll just adjust the scope accordingly if they need to take over. But you should use your left hand. Okay, let's see. Okay, I have this question here. When do you? Oh, I'm going to answer this question. Using longitudinal versus burst versus pulse. Okay, so I would say that it's okay to use complete longitudinal in cases where you don't think you're going to lose a lot of energy. If it's a very, very dense lens, I go ahead and I like to use pulse. So pulse that will minimize the amount of energy that I am using. ultimately. So burst is the kind of thing that you have to adjust if you're going to be grabbing onto dense lenses. I think that burst is helpful in those particular cases. Okay. Oh, okay. Let's take a look. Okay, I have somebody who's going to shift to Simcoe from Simcoe to bimanual INA. How higher is your irrigation from aspiration to avoid collapse of the AC? The shift is a bit scary. Yes. I love the Simcoe cannula. So I would say in the case of going to a bimanual INA, the first most important thing is to double check that your INA handpiece is, again, your irrigation has to be bigger than your aspiration. They should not be the same size. So I would say that if you're worried, I would go with a 0.5 millimeter or a 0.4 millimeter on the irrigation, and then your aspiration should be 0.1 millimeter less. So if you have a 0.5, I would go to 0.4 aspiration. If you have a 0.4, you should go to 0.3 aspiration. So that's the first thing, is make sure that your irrigation is higher. And then the second thing is you can go very high with your with the bottle height. So I would go ahead and put that up at 100 or 105, and just be aware then as you are pressing the foot pedal, you are again controlling the amount of aspiration linearly. And so you just be very light on your foot pedal when you're starting your bimanual irrigation aspiration. Okay, if you have to place an IOL on the sulcus, what power do you use? So yes, so because you are placing a lens a little bit more anterior, many people will decrease your IOL power by 0.5. So if you were a 20 in the bag, a 19.5 in the sulcus. However, if you're going to do an optic capture, so in other words, you're going to place a lens in the sulcus and then push it back into your, to capture it in the capsule rhexis, then you don't need to adjust. So it's just where the ultimate effective lens position is going to be. But I would say the vast majority of people probably adjust by decreasing your IOL by 0.5 if it's the same A constant. So again, you have to be sure that the A constant of your IOL is the same. For those who are using the Alcon lessons, Alcon IOL is slightly different. So again, you want to make your calculation according to the A constant of your lens. Okay. Intraocular adrenaline on floppy iris syndrome. Many of us have tried it. Sugarcane was popularized where there was a combination of epinephrine and lidocaine, which seemed to be quite effective. And so you can look it up. It was popularized by a surgeon by the last name Sugar, S-H-U-G-A-R. And that is something that some of us use. I find, though, if the pupil's going to come down, it's going to come down. And it's not so much the dilation that's problematic as much as the floppiness and the prolapse through the wounds. And so because of that, I tend to like to use the rings rather than just dilating with epinephrine. Okay. CTR is good for a dehiscence of 3 clock hours or less. What do you use if the dehiscence is more than that? If the dehiscence is more of that than that, okay, there are a couple of options. Number one, you can put 2 capsular tension rings in. Number two, you have to make an assertion then you're talking about not just the problem with the capsule, it's going to be a problem with vitreous coming forward. So then you have to make that decision as to whether you're going to try to save that capsule or whether the vitreous becomes so problematic that you're not going to be able to save it. And so then in those cases, then you have to determine whether you're going to actually take that entire capsule out and then where you're going to put the lens, whether it's an anterior chamber lens, suturing a lens to the iris, suturing a lens to the sclera. So those would be more advanced cases that you would have to consider. Okay. Okay, and there's a question, where to put the tension ring in the sulcus of the bag. So I'm going to say 100% of the time you have to put the tension ring in the bag. This is not a ring that's going in the sulcus. And the purpose of the ring is to redistribute the forces around the bag, and in order to expand that, in order to prop up that area where there's a dehiscence. So there's no use for it if it's in the sulcus. So be sure to put that capsular tension ring in the bag. Okay. And okay, what is principal and intelligent phaco mode in Infinity and Centurion. What that does is when you have full occlusion at the end of vacuuming up a piece, what will happen is you'll get a very there can be some obstacle to the very last part of your piece. And so what intelligent phaco does, when it senses that complete occlusion at the end of a piece, meaning that the vacuum is not effective, it'll actually give you a very tiny burst in order to get through the end of that piece. And then it's a millisecond burst, so it prevents post-occlusion surge. And so that's the purpose of intelligent phaco. And you can turn it off just by pushing that IP button on the machine. Okay. How high is the IOP that you recommend to be maintained? Okay, so this question has been asked: how high do you recommend the IOP to be maintained during phaco? Do you maintain that same IOP during surgery, or do you make adjustments in routine cases in different steps of surgery? And the answer is yes, you have to make adjustments during different cases, parts of the surgery. So when you are sculpting, you do not need to have high IOP because you don't have high vacuum. So really it's a balance between the irrigation and the aspiration of fluid outside the eye. And so when you have high vacuum, you want to have a higher bottle height or higher. So we are equating IOP with bottle height with irrigation. And so all those three things you'll have to adjust according to what you're doing in your particular case. Okay, how do you dilute epinephrine in the solution? Okay, so the dilution is usually, I use epinephrine in my bottle, and I'm using a 1 to 1,000 vial, and then I dilute it again 1 to 1,000. So it's 1 to 1 million in your bottle. Okay. Do you prefer? Okay. Okay. Let's see. I'm going to answer a few more questions here. Let's see here. Intraoperatively, how do you manage a hazy cornea? Okay. If you have a hazy cornea intraoperatively, you have to determine what the reason for that hazy cornea is. Obviously, if you have corneal scarring, there's nothing you can do about that. You're going to have to just see around it, or you know, make other arrangements or replacing that cornea before surgery if it's truly a scar. If it's haziness because of edema, then you're going to have to make adjustments accordingly. A, you have to protect your endothelium with a dispersive, and B, you might have to scrape the epithelium if that's really causing a problem. Okay, I think we might be concluded. So I want to say thank you, everybody. It's really been a privilege. I really enjoyed very much this entire session, and I hope to be able to present to you again. Thanks very much, everybody.